Hello, everyone, and welcome to another episode of the All Out Coach podcast. My name is Tim. I'm your host. This is your show and opportunity to advance ourselves and also our teams by focusing on the depth, the knowledge, and meaning from one conversation to another. Today, my guest is one of the most dedicated people that I know. She's a renowned leader in the world of pharmacy. Her name is Leigh Briscoe-Dwyer. I've known her quite a long time. She's currently the director of the pharmacy at the United Health System, a comprehensive healthcare network that includes many hospitals in Binghamton, New York. She's also the board member of the American Society of Health System Pharmacists, or ASHP. Throughout her career, Leigh has held many different responsibilities that spanned healthcare systems, such as her vice president role in the network of pharmacy at Westchester County Medical, her other administrative executive roles at the North Shore Health System, which is now called Northwell. She continues to be a mentor to pharmacists across different facets of this profession as well. The clinical experiences and responsibilities she's held, and also in the industry as well. Early in her career, she was the medical science liaison for Pfizer. I mentioned that I'd known her a long time, and I've been able to reconnect with her now just recently. But what I find remarkable about her enthusiasm, her passion for the pharmacy is that after every single one of her presentations that I attended, whether it was at a national meeting or a regional meeting, I left them more inspired, more empowered about myself as a person, as a leader, as a pharmacist, and the unlimited potential that this profession, this trusted healthcare profession has. And so I'm particularly happy and truly privileged to be able to reconnect with you, Leigh, and to have some of your time with me here on All Out Coach.
Well, thank you very much for those kind words. It's a pleasure to be here and talk about, some of my favorite subjects, which are pharmacy and leadership and making a difference.
Sure. I introduced some of the highlights from your career, but I'd like to ask you to give your perspective of some of the biggest accomplishments in your career and also the direction and your inspiration currently, Leigh.
Sure. I always say that, pharmacy chose me. I didn't choose pharmacy. Pharmacy chose me. I had had what you would consider to be a Cinderella career. To be able to sit at this point in my career and look back and say, every step that I've made in my career, I've been able to build on what I've learned before. But to sit here and say that I'm on the board of ASHP, that's a dream, and I'm still in the pinch me mode for that. It's hard to say that there's a highlight. I think that the thing that I love most is making an organization better, knowing that it's better when I leave it than when I got there. Having people identify that they are in fact really good leaders and to have them find their niche and to really see them grow and blossom in the roles that they have. And I think that the thing that I am most proud of is probably when someone comes up to me at a meeting, big, little, national, local, and they say, I remember you and I remember something that you said that still stays with me. I think that's my greatest accomplishment.
Were there some mentors that you aspired to early in your career that helped fuel that passion, Leigh?
Absolutely. I have said on more than one occasion that, I would not be sitting where I am today without Dr. Tom O'Brien, who was the director of pharmacy at Bassett Hospital when I did my internship hours there in my last year of pharmacy school at Albany. And, Tom saw something in me and kind of sat me down and asked me what my plan was. And I told him what my plan was. And he's like, yeah, that's not a good plan. He's like, this is where you need to go. This is what you need to do. And that included going back to school and making sure I got my PharmD. And he was the first person who got me involved in my local pharmacy organization. When as a student, he said, by the way, nobody make plans for tomorrow night because there's a meeting that you're going to be going to and I'm taking you. It wasn't, do you want to go? It was, we are going to this meeting because it's part of your obligation. And so, and I'm very, I'm very lucky that that I can still reach out to Tom, and I still see him, and I still thank him profusely every day for helping me get on this path. And I think that's why I take mentoring so seriously, because I really don't know where I would be if I didn't have, somebody like Tom to help me to get started and to kind of keep me on my path. And I think that's so it's one of the reasons why it's so important to me. And one of the things that I always talk about with students and with young leaders is, to develop that core group of people around you that you trust. Not a big group of people, but a very small group of people that you trust, that you run stuff by. So, look, I've got this opportunity. It's moving outside my comfort zone, but it's a great opportunity. I've got, I might have to move, I might not have to move, but, and they'll give you honest feedback. And, because I think that sometimes, trying to look into a mirror, it's difficult to see, what your true strengths and capacities are. So you use that group, I call it your tribe. You use your tribe to help you make some of those decisions and keep you on task.
And you try to be, I guess, the best student you can be, right, of those mentors. Which
yes,
yeah,
absolutely.
Leigh, we've made many advances in healthcare. We live longer than ever, yet a lot of disparities continue to exist among elderly, among many patient populations. I know you're very passionate about this. Can you talk about the disparities in healthcare currently, what your perspectives are on potential solutions?
I think that, the COVID pandemic really, I identified some of these disparities that we have in healthcare, because we saw differences in populations who both contracted COVID and those who did poor versus those who did well, those who died versus those who didn't. And we're still kind of teasing out some of that information, but I think that those numbers are certainly valid. And, kind of give us a target of, okay, so now that we're starting to recover and dig out, now we know what we have to do. I think that when we were able, for example, to move to a lot of virtual physician visits, virtual education, which I think was great. It kind of showed that healthcare, which sometimes we think of as trying to turn the Titanic, right? We're actually a lot more nimble than we thought we were. But I happen to, live in an area. I live in an area in upstate New York that's very rural. I've also lived in areas down in the city, which are very, very urban, right? So, but I've always, my home and the place that I was raised is in upstate New York, in a very rural area. And broadband internet is still not available to 100% of the people. And so I've had friends who've actually moved during COVID because their kids were being taught online, and they didn't have internet services. They literally had to buy a new house and move there so that they could have good internet service. I think we saw a lot of frustrations with people trying to get online to schedule an appointment for a COVID vaccine. Because if you think about some of those initial groups at the beginning, right? So it was people who were over 65, people who had a lot of concomitant disease states. Not a lot of those people spread all over the country had the same access to the means by which you needed to make an appointment. All the appointments in New York State were online. If you don't have internet, you don't get an appointment.
Yeah.
And so, looking at, where I am in Binghamton and in Johnson City, we're doing a lot of outreach, because there are, in order to reach herd immunity for COVID vaccination, you need to meet a pretty significant percentage of the population. Not all that population is going to come to you. You have to go to them. So we go to them for homeless, for homebound, for behavioral health patients. So we actually, we have to make that determination that healthcare is not always, people aren't always going to come to you in healthcare. You've got to do the outreach to them.
Yeah.
And I think sometimes it's difficult for people who live in a very urban area to realize that there's not a large chain drugstore, 2 stores on opposite corners everywhere you go. There are counties in upstate New York where there's only one hospital in the entire county. There are some places, where I work right now, where if you get a discharge prescription from an emergency room at 2 o'clock in the morning, it's a 20 to a 30-minute drive to get your prescription filled.
Mhm.
And so it's looking at those types of things that I'm actually interested in doing right now to try to figure out how we can bring healthcare to people, who are in more urban and disparate areas.
Yeah. One of the areas that I always wondered about, and I saw a gap in our healthcare, is the continuity of healthcare, and the medication reconciliation is how we refer to it in pharmacy, or how we used to refer to it when I was a student. And so, how do you standardize the highest quality of care across the different healthcare providers, systems, insurance plans, to make sure that the right patient gets the right care by the right provider at the right time?
Well, I'm going to preface this by, if I actually really had the answer to this this question, we
Yeah.
could be having this conversation on my private island in Bali. Okay.
Yeah.
But I mean,
Those are the kinds of questions we ask on All Out Coach, Leigh.
So, being that I'm not in my private island in Bali, so I mean, that is one of the biggest issues that we have, right? Is health, even healthcare within a system is somewhat disparate, because, and I think that pharmacy has a significant role to play here, because pharmacy, I kind of look at pharmacy as the central warehouse, because no matter who the patients go see, their cardiologist, their gastroenterologist, their rheumatologist, their internal medicine person, if they're going to be getting a prescription from them, they all come to me. They all come to the pharmacy. So I think that, realizing that comes with some responsibility to say, okay, so I have this, this task now of not just filling what's in front of me, but making sure that it's appropriate in comparison with everything else that I know about the patient that maybe some prescribers and some providers don't know. So, and that's where, again, medication reconciliation, or MedRec, comes into play. And then, I think that we've shown in a lot of different studies that pharmacists do medication reconciliation better. I think it's because of the fact that we do have some, we've got more of that information, but it's very time consuming. And it's not something that you can, that you can kind of spit out really, really quickly. And so I think that people who are really invested in fixing this problem and in making it better, they need to realize that it takes a lot of manpower and it takes a lot of time to make sure that we get it done right. And I think that the first thing about standardization comes with figuring out ways to have access, through different medical records, through different pharmacy records. I know in New York we have a RIO, which opens up some information to us, but I think that there's buckets of information out there, and we're just not good at capturing it and being able to filter it and figure out what some of the answers to the questions that we have are.
Yeah, and I have family members who have worked many years, at healthcare professionals themselves, whose insurance plans change, right, from one year to the next.
Every January.
And then they're able, and then they have to, they go through this delay in treatment that's critical for even cholesterol, for kidney disease, for hypertension. And, I see them being, having to face a lot of problems that could be, avoided with more continuous care. As a follow-up to the technology that you have available at many different hospitals, they also don't communicate with each other. You don't have this one standardized, let's say, prescribing system across the entire healthcare system. Right? So how were you able to close those gaps with using the latest technology, in your leadership roles in these healthcare systems?
Well, I'm actually very fortunate now because at UHS, they actually just rolled out the Epic system across all their hospitals. And we actually use the same Epic system in our 6 retail stores. So for the first time, I'm actually in a position to see what happens when I actually do have that reach for both inpatient and outpatient care.
Mm-hmm.
And I think that, again, one of the important things there is to make sure that you have everybody on board. You have your providers on board. You have representatives from all of the different areas that work as you're rolling this out and building it, so that people have what it is that they need, so that they can be champions for it, so that people don't try to do a workaround to try to, to get something out of it that it's not built to do, because they want to see what they used to see, when they have to realize that, okay, this is going to be a step forward. I'm going to get more out of it than I'm going to lose, but I may lose, I may lose some of my autonomy, but through standardization, you get quality and you get safety. And I think that those are things that are certainly worth losing perhaps a little bit of autonomy for.
Mm-hmm. Are there particular patients, diabetic patients, which I know you talked about, and infusion pumps technology, where it becomes a little bit more challenging to standardize some policies across the different hospitals, right? Can you talk a little bit about that?
So we actually at one of my healthcare systems, we rolled out smart pump technology to a large number of hospitals within a 12-month period.
Uh-huh.
And that took a lot of, I think the biggest thing that if anybody's trying to do a big project like that, the first thing you have to do is you have to over communicate. Yeah. You have to make sure that everyone is aware of what's going on. You have to you put choices out there. We actually used a almost like a chat room to discuss some of the changes that we were making to smart pump infusions.
Mm-hmm.
And then and once a week, we actually had an open forum where people could come and ask questions. And what we found over time is that the audience actually started answering their own questions. We actually didn't have to answer the questions as the kind of the owners of the smart pump process, because everybody else said, no, this is why we have to do it this way. And I think that made the actual implementation easier, because there was ownership across the board. It wasn't pharmacy coming in to do something to everybody else. It was a group of us all coming together and rolling out something that was, very large, but based in patient safety. And we would not leave, and we wouldn't leave a hospital until we knew it was right, until we knew that we had 100% of people on board, and it was being done right, and it was being run right and used correctly. All the questions were answered. Then we could in fact move on to the next place.
Yeah.
But and standardization is a little scary, again, right, because people like what they're used to. But I think that asking people to be open to change, and to, again, be available, answer their questions, have them look at information and use the technology at first whenever possible, to take away some of those fears. I think is really important. And again, you cannot over communicate when you're making a big change like that.
Yeah. So that's clear emphasis there on communication. And that's what always struck me about you, how clear you were and how you mentored others, and the culture that you embraced in your teams, in your hospitals. And that's my follow-up question then. How were you able to bridge the technology with the kind of culture you wanted to create, to empower your teams, pharmacists, to challenge maybe other partners in their healthcare team?
Well, there's a saying out there that says, culture eats strategy for breakfast, right? Yeah. So if you have to start with culture, and within the culture, you have to start with trust. And that's probably the biggest issue is building trust amongst people. But when you are able to finally do that, and people are going to test you, and you have to stand by your the decisions that you've made, and how you want to be, and the culture that you've chosen. You need to stand by that. And some people are going to embrace it and jump in and stay with you, and some people are going to push back. And at some point in time, you have to make the decision of whether or not, no matter how brilliant that person is, if they're toxic to the culture that you're trying to create, sometimes you have to let them walk away. But so the first thing you have to do is you've got to build the culture. You cannot build a team. Building a team on bad culture is like building a new house on a foundation of sand. It's just not going to work. And you must have pretty on the outside, but it's going to fall apart.
Yeah. And one important skill probably that you had mastered was being able to tailor that culture, not just in one pharmacy, but across the entire system of healthcare system, as you had leadership responsibilities that spanned the entire healthcare systems. So you tailored that culture to the needs in that particular hospital, those patients, right? Did you find that as a challenge, or any tips you have for just scaling, let's say, a culture as a company grows, or as the pharmacy or your team grows?
My mission always was to demonstrate how pharmacy and pharmacists can impact patient care to the better. Again, no matter where you go in healthcare, if you're looking at a health system, right, medications touch probably 95% of the people who walk through the door. It's very rare now that you actually come into a health system and don't get treated or tested with some kind of pharmaceutical agent. So,
Mm-hmm.
so that's big, right? And then you think about the other two professions, right? So you have pharmacists who are doing this dispensing, but you have providers who are writing those orders. And so if you have a good medication system and good formulary and good policies in place, they're going to be happy. And provider satisfaction certainly drives the culture of an organization.
Mm-hmm.
And then if you work with your nursing staff and make sure that the medications that that you have are available, that they're available in the most ready to use form, that you build safeguards around there for your nursing staff, because everywhere else in the medication use system, there is there's a parachute, if you will. Right. So if a provider orders something and it's wrong, pharmacist catches it. If a pharmacist dispenses something wrong, the nurse catches it. There's nobody there to catch the nurse. Right. But that's what barcode administration is for. Barcode bedside administration of
Mm-hmm. Yep.
medications,
Yeah.
and using the smart pumps. So now they finally have a net, if you will. So, I think that if we're going to give, for example, if we're going to give our nursing staff those tools, we have to make sure that they are up to date, that they're valuable, and that they make sense. And so that if we're going to ask you to use this 100% of the time, we better make sure that it's a good product that we're asking them to use, and that the drugs are going to be there. So all those three things, can drive a positive culture around medication use, and to see pharmacy as, as a partner. Right. So often we're considered the drug police, right? We're the ones who call you and tell everybody, you can't use that. We don't have that. It's restricted. It's not formulary. But, so we really try. I think that's probably if there's one thing to take away from this, that's to try to build your communication, and therefore your culture, around the fact that, look, I'm not here to be the drug police. I'm here to be your partner.
Yeah. Mm-hmm. You mentioned provider satisfaction as one of the metrics or indicators of success. How did you approach metrics, KPIs, in different healthcare organizations, in pharmacy in general?
Yeah, so metrics are hard, right? So there's so many different things that can go into measuring productivity, for example.
Yes.
And you look at bed size, you look at doses dispensed, you look at your critical index, your patient index of how sick they are. It's obviously, well, I don't know if it's obvious, right? In pharmacy, we know that it's much more difficult to care for pediatric patients, for example, than it is to care for adult patients, because in pediatrics, everything is weight-based, and almost all your doses are individually prepared. Right? It's it could be because all the weights are different. So it's really hard to compare apples and apples when you're dealing with a pediatric population. Compared to anything else. And I think that, one of the traps that people get into is there are some national benchmarking systems that are used, and so then they try to compare, your hospital pharmacy to another hospital pharmacy, and without taking into account, all those systems tend to look at are the productivity metrics. Right. So you have this many doses, you have this many orders, you need this many people, but none of those systems take into account the fact that you have pharmacists that are in the ICU preventing patient deaths. You have pharmacists in the emergency department driving good care and good quality. You have pharmacists running your antimicrobial stewardship program. You have pharmacists running your opioid stewardship programs and some of your pain management programs. So, if you don't take into account those things, you're not really going to get a true picture. And you're going to, as a leader in the pharmacy, you tend to spend your days fighting for FTEs to be able to maintain the clinical programs that, if you take away too many pharmacists,
right,
your quality is going to go down and your costs are going to go up significantly. Yeah. And so you got to trying to find that middle line. And there's no algebraic equation for that. Yeah. Every organization is going to be different.
Yeah, I appreciated those comments very much. The relevance and the significance of pharmacists. That's really why I became a pharmacist, Leigh, and why I chose my first project as a postdoctoral fellow to be one that was focused on medication errors prevented by pharmacists, because there was a lot of data, of course, where you have pharmacists be consulted by physicians during grand rounds, they reduce errors, and there's a lot of data on that. So there was a multidisciplinary team early in my career that I was able to publish. And when I started actually my career in pharmacy and in the pharmaceutical industry, it was actually the safety that drove me. I wanted to impact bringing more safer medications to the patients. So your approach to technology has been very flexible. And you mentioned to me also telepharmacy, not just telemedicine. Can you describe the prospects of telepharmacy from your perspective as well?
So, one of the things that we know for sure is that when pharmacists are able to counsel and communicate with patients, they have better outcomes. And we know that from what the first pilot study that was done looking at collaborative drug therapy management in New York State involved a number of different disease states. But when you had a pharmacist involved, the outcomes tend to be better. Okay, so we know that makes sense. That's been proven. But how do you reach all of the patients that you need to reach? And how do you reach them at the time that is best for them? And so I think that we've learned we've learned a lot through COVID that that a lot of this technology is possible and a lot of this outreach is possible. So I think that we need to make sure that we don't take any steps back as we dig out from the pandemic, and continue to use things like telepharmacy to be able to reach patients when they have questions, to be able to check in with patients on a routine basis when you normally wouldn't have. Again, normally you'd have to wait for the patient to come to you, and going to a doctor's appointment, a provider appointment, it's not easy. So you have to get there, you have to find a place to park, or you have to valet park, and then these hospitals are big, because they've expanded and they've grown over time. So now you're walking the equivalent of a city block to get from the front door to where it is that you have to go. And so it just, the end of the day can be difficult. Again, not the time maybe to sit down and try to explain, and do a whole lot of counseling about a new medication regimen. But maybe later on when they're home and they have some of their caregivers around them, that might be the best time. Because now I'm talking to you and I'm talking to your daughter or your son who is the caregiver, or you might have a home health care aide who's there. That's a really good time to talk to you, because now we're involving everybody who's part of that process. So, we know the technology is there, and now it's just a matter of, will there be reimbursement, or will there be some kind of maybe perhaps grants to offset the costs that are going to be associated with that, so that we can demonstrate the overall impact on patient care, which would be a significant decrease in cost. I'm sure that would pay for itself.
I know that you're a board member of the ASHP, Leigh, and you're part of the 2030 initiative, right, from ASHP, the Pharmacy Advancement Initiative. So can you give us a preview of how you see the future of pharmacists and their reputation on the healthcare, in the healthcare profession evolve?
Sure. So the Pharmacy Advancement Initiative for 2030, has grown out of the first program that was started in 2010. And so every decade, we stop and look at, okay, what have we achieved in the last 10 years and what do we want to aspire to be 10 years from now? So when you first look at the PAI initiative, some of these things are really significant, these changes. But again, we're looking at something that's going to happen over 10 years. And 10 years really, in some sense, it's a long time. But if you don't plan for it, it will be over before you know it. So, what we hope that people will use the PAI for is to develop, take a couple of the aspirational goals, build them into your strategic plan, so that that you can progress. And so there are different areas of the PAI that you can look at. You look at pharmacist education and training, pharmacy technician education and training, harnessing data and technology. And then, when we look at where I hope pharmacy is in 10 years from now, I hope that, pharmacists are embedded in the teams. I think there's going to definitely be a team approach to healthcare. As fee for service goes away, there's going to be less pressure on, if I pay a pharmacist to do this, then I'm not going to, have money over here to do that. If there's going to be one reimbursement, and the better care you give your patient, the better your reimbursement is, then pharmacists are of course going to be part of that team, because we know that having pharmacists involved gives us better outcomes. So that's my goal. I think that pharmacists in some ways are too tied to product instead of the patient, right? So when you think of even today, when you think of pharmacy, you think of pharmacy and you relate it to a medication. What I'm hoping is that pharmacists are tied to patient and to patient outcomes as opposed to drug distribution.
Okay,
I think
that's an important distinction. Yeah.
Yes, and the advances that we've made in both pharmacy technician training and education and accreditation and licensure and registration, along with technology, they're going to take care of the distribution part. Right. If as a profession, if you're banking on having a role in drug distribution in 10 years, I think you're going to be missing out. So you really need to focus on, so now that we've distributed the drug, what's the best way to make it work?
Yeah.
Right. So a patient having a Ventolin inhaler in their hand or in their home doesn't do anything if they don't know how to use it right. Right. That's where pharmacy is going to play the role, in making sure that they're using it appropriately, making sure that there's follow-up to say, all right, since we've made some adjustments to your care, or since we've made sure that you've got the things that you need, you haven't had to go to the ER, in 6 months or in 12 months. Those are the huge impacts that pharmacists can make, and that's where we need to be thinking. Pharmacogenomics and individualized therapy based on a pharmacogenomic activities, that's going to be significant. There's going to be much more of that in 10 years from now than there is today. Just like that's where we're seeing the specialty pharmacy growth as well.
What you mentioned there about tying pharmacists' role to patient outcomes more directly, I think it's consistent throughout many different fields of pharmacy, clinical, in the industry as well. And that's why I consider you a true patient advocate, not just a pharmacy advocate, but a patient advocate, because through all of your involvement, your mentorship of, let's say, early career pharmacists, you always brought back that, the duty that they have, that we had, to patients, not to our profession, and then also to patients, to the leadership. So I really thank you for making those comments there, because those who will listen, I think, pharmacists or even those interested in the pharmacy career, I think they can appreciate the role that pharmacists have on patients' outcomes more directly. So pharmacists are also becoming more entrepreneurial now, right? Yes. And yes, that's the one observation I've made. And so the CDTM, right, collaborative drug therapy management, and MTM, right, medication therapy management, how have they demonstrated the pharmacy's efforts and their time? how do you think that, how do you envision that their reimbursement increase in the future?
Well, again, reimbursement, I think is, it's a tricky issue right now.
Mm-hmm.
Again, I think that, again, tying yourself to the outcome versus the reimbursement is going to be very important, because fee for service is going to go away. Right. So if you have outcomes and data based on a fee for service model, you can't necessarily translate that into an outcomes model. So I really think that what we need to be focusing on right now is developing the impact on patient outcome. So that as the insurers start to look at the different types of payment models, we'll be ready to be able to demonstrate that this is why we have to do this. So I think that and you said something about pharmacists being entrepreneurial, and I really think that's something that a lot of pharmacy students, for example, don't might not recognize, and I think it's important that you talk about that. Back years ago when I first graduated, with my bachelor's degree, you only had a couple of options as far as your career path. Right. You could work in a store, you could work in an independent, you could work in a chain, you could work in a hospital. There wasn't a whole lot of nursing home, there may be a little bit of consulting, but there weren't as many options. Today, you have the pharmaceutical industry in pretty much every facet, whether it's in sales, in marketing, in outcomes, in in regulatory affairs. Pharmacists are everywhere. I think that you see pharmacists opening businesses that are medical related, but not necessarily just drug related. And so I think that it's a fabulous springboard. Many people now get a PharmD in combination with an MBA, because when you look at the fastest growing segment of healthcare, it's medication use. Right, so that number keeps growing over and over and over again. So what you need to be able to join that expertise about drug therapy with expertise about finances. And to be able to, as we get more and more transparent with with the financial outcomes in healthcare, we need to be able to talk about, well, this is what it costs me to treat somebody, and this is what I get paid to treat somebody, and is there a way to make that, to change that discrepancy if there is one? So right now, I think that we've gotten really good at the clinical side, but we need to now kind of marry that to the financial side, and I think that's where the combo with the MBA is a great idea. You're looking at people doing masters in public health. I mean, what a year for public health. Right. What a year to be able to talk about what herd immunity is, and the contagiousness of a disease. Being able to speak to that, and being someone who's trusted, and somebody whose people think your opinion is valuable, and that's a way to get people to have faith in the system and have faith in medicine, and to say, I was a little concerned maybe about perhaps getting my COVID vaccine, but now that I've spoken to you, I feel better about it, so I'm going to make my appointment.
Yeah. Leigh, when I spoke to you recently, I mentioned to you that I work in the pharmaceutical industry for most of my career, 16 years, but I never forget the fact that I'm a healthcare professional, that I'm a pharmacist. And in various different situations where I've presented to P&T committees, who decide on the formula, what drug to add or not, they really restrict those representatives from the pharmaceutical industry to only speak on the label, or even do not even let them discuss the product. Where I had to remind that P&T committee and those decision makers that, look, I am a healthcare professional. And whether or not I'm a patient, we all seek healthcare at some point, and so does a lot of the P&T or the hospital administrators, or those who decide on policy and so forth. So as a way to find common ground, right? So my question really is, how do you think that the pharmaceutical industry can partner more with different facets of pharmacy you mentioned, in clinical, and payers, health insurance companies, Are they doing a good job, or how would you envision seeing those relationships flourish in the future between the industry and other areas of pharmacy or
Well,
healthcare?
I think if you try to view that relationship as a partnership,
Mm-hmm,
and so, so the things that we need is we need transparency, we need honesty, we need integrity on both sides. I think you have to respect that everybody here has a job to do.
yeah.
So, when it comes to, new drug therapy, it's always, it's one of the things that will send, panic into a pharmacy director's, heart, because,
Right.
I did my budget, I submitted it in October, it's January 2nd, I'm already over budget, right? So, and
Right.
now this is going to hit me. So, and that's kind of like your first gut instinct. So, I look at a pharmacy budget, for example. I always tell my P&T communities that we look at our pharmacy budget as an investment, right? So the board of directors of our health system is investing so many millions of dollars, sometimes hundreds of millions of dollars, in pharmacy. Okay, it's not a spend, it's an investment, because we're using their money to buy drugs that then obtain an outcome.
Mm-hmm.
So the more information we have on outcomes, and I think that, again, coming to the realization that when there is a new agent out, that, that we're not going to use it in every single person who has that DRG, right? There's going to be, in all likelihood, there's going to be a role for it. Let's work together to find out where the best role is. So you're not going to get 100% of the patients, but I'm not going to get 100% of the spend. So this way we don't have to hate one another, right? So I think that that's one of the things that we have to work out is there's going to be a role. Where is that role? Is it on the inpatient side, or is it in the ambulatory setting? And if it's in the ambulatory setting, where does it fit? And even in the hospital setting, where does it fit? And how do we make sure that the claims that are made when a new drug comes out are in fact realized 6 months down the road, and 3 years down the road.
Mm-hmm.
So, I think that, looking at changes to formulary, maybe not as, there's never really an end to a story, because it's really something that's always going to be evolving. But having the commitment on both sides to be able to see that decision through and make tweaks along the way, I think that could be, again, like I just described, a partnership.
Yeah.
It's working as a team. I think that everyone would admit that, over the course of these last 12 months, the interaction between hospital pharmacy and the pharma companies has been a very positive one. Nobody really knew what we were getting into, but when we needed more drug, we could pick up the phone and people got us drug.
Mm-hmm.
And, I think that it was it was then that we realized that the relationship is a lot more than just, a superficial one. That it is, there is more, it's a deeper relationship. And I think that we need to, again, capitalize on that and figure out how we can work together so that both sides get what it is that they need.
Yeah. Leigh, you've had a very illustrious career where you've been able to leave many healthcare systems much more productive, much more effective, much more innovative and relevant. And so you've made strong contributions. What leadership message or lessons would you share with our pharmacists who may listen, and as well as anyone else who finds All Out Coach inspiring?
Well, I mean, as I always say that, I always tend to end a lot of my messages with the fact that I love being a pharmacist. It's not just what I do, it's who I am. And, and I think that that's one of the reasons why I am so passionate about it. I had the privilege of hearing Billie Jean King speak a number of years ago, and she made a statement, and that has resonated with me ever since. And I probably say it every single day, that pressure is a privilege because it signifies relevance. And there's pressure in being a pharmacist, whether you're a director, of a 27 hospital system, or whether you're, a staff pharmacist in a critical access hospital. There's still pressure there, but it's there because you're relevant. It's there because you're important, and no matter where you are, you're making decisions that day that are going to impact people and impact their lives and the lives of their families. And, there's pressure that comes with that, but there's joy that comes with that.
Mm-hmm.
And I try to focus more on the joy than on the pressure. But being a pharmacist is it's not a job, it's a calling. And when you answer the call and you're there to do whatever it is that it takes, that's when you can go home every day saying, something, today I made a difference. And sometimes it's going to be a big difference. Today I vaccinated 427 people, right? So now there's 427 people who, if they get COVID, are not going to die. I mean, that's a pretty big difference, right? And some days it's, there was an elderly couple and they were wandering around and they were lost and they needed me to take them to the lab so that they could get some blood work drawn. Not as huge perhaps, but just as much heroic. Yeah. And so if everybody, no matter who's listening to this, if everybody just choose to make a difference in one person's life every single day. Okay, and that's going to be 365 people who are impacted over the course of the year. Yeah. And so it was important that you were here, and you're definitely relevant. Yeah.
Thank you, Leigh, so much. On behalf of a lot of my pharmacy friends, pharmacists, my network in the industry, in different hospitals, you've enriched this profession, and you continue to be an advocate. That's why I'm very grateful to you as being our leader for the profession.
Thank you so much. It's a great time to be a pharmacist.
Great. That's great to hear also. Great.
All right. Thank you, Tim. It was great to talk to you.
Thank you. You too, Leigh. Thank you so much.